Hello, I'm Anna Marie de la Vega, and this is Focus. Thank you for joining us today. Our guest this time is Dr. John Lazar. He's the Chief of Thoracic Surgery and the Director of Thoracic Oncology at Ascension Saint Thomas. Welcome, first of all, to Focus.
Thank you, and thank you for having me.
So what does that mean that you do with all of those big titles?
So thoracic surgery is surgery of the chest,
Okay.
And that can include the chest wall, so your ribs, the breastbone. It can also include the lungs and the airways that connect them, and it also includes the esophagus and some of the soft tissue that's also in the chest.
Okay, so everything in the chest
Except the heart.
except the heart.
We don't do heart. I don't do hearts.
I got you. And the Director of Thoracic Oncology.
Correct.
Which means...
So that includes all of those tissues that could get cancer, but it also means not just surgery, which is one way of curing cancer or treating cancer, but I'm also in charge of coordinating medical oncology, so things like chemotherapy, immunotherapy, as well as radiation oncology, which is just a different way of treating cancers.
Okay. So is breast cancer an external part, or are you talking about inside?
Inside. That's a great question. No one's ever asked me that. So yes, breast cancer would be considered something else. Now, if it spreads into the bone or inside the chest, then I would work with the breast surgeon and the breast oncology team.
Okay. There are always a lot of changes, a lot of advancements. In the past 50 years, we've just come so far. In the past 10 years, 5 years. And you are the man who I've heard is always at the forefront of these changes, these improvements, these new things that are going on. Tell us kind of what's new if we're looking at something going on in the chest, cancers or something like that.
One of the things that we're very interested in at St. Thomas, and specifically our program, is this notion that the nodules that we're finding are getting smaller and smaller. So imagine trying to find something that's half an inch or smaller or even an inch that's in the chest. And because we're doing minimally invasive, we can't really run our hands over and feel it. We are using a new drug that binds to the cancer and then excited by a special camera so that we can see it and we can take it out without having to make even a bigger incision or just watching it. So the patient then has to live with this cancer. So our biopsy abilities have gotten better. Our imaging abilities have gotten better.
Whoa.
And so now it's up to surgery to basically catch up with those innovations.
And how would surgery catch up?
So there's a drug called Cytolux. It's made by a company called On Target Laboratories. And they've been working on this for probably over 10 years, but it's now just been FDA approved. It's not in every hospital, but basically it's an infusion, and the patient gets it about an hour before surgery. Then they go into surgery. We do our surgery the way we would normally do, except we put in a different camera, and it excites something called folate molecules, which we have in all of our body, but we express in a higher way in the cancers that we're looking at. And instead of just kind of looking at a blank surface and trying to find it, it lights up whether it's blue or orange or green. We also have like a monochromatic one where it's black or white. And basically all the guessing is gone.
Whoa. And
we can go in there. And we use it in a couple of different situations. One is, and I've used it with patients who have maybe say colon cancer or breast cancer. And sometimes those tumors go to the lungs.
Oh.
And so that's what we call metastatic disease, stage 4. And so when I go in there, I'm trying to cure them of that metastatic disease. But sometimes we only see one focus of it.
Right.
This may show us something that we weren't even expecting. It didn't show up on the CT scan, or it didn't show up on a different type of scan, which is called a PET scan. And so we look for what's called occult disease. So that's one thing we do. The other thing that we do is look for it in places like I talked about before. They're very small. They're in areas that I may not be able to see very well, and which with minimally invasive, I'm really depending on them being closer to the surface of the lung. With this drug, they can be a little bit deeper, and then I'll still see it. And then the third thing that's really great about it is that it can show me, once the specimen is out, whether or not the margins are negative. So when we talk about removing a cancer, we want to make sure we're not leaving any microscopic or bigger disease behind. And so when I go and take it out and I put it on what we call the back table, which is different than the operating table where the patient's at, I can then shine that camera on it and it will light up the margins, which are the edges, so that I know that I've taken everything out.
Holy cow.
Yeah. So
that's
it's really
amazing.
Good. Yeah.
And you're using that now?
We are using it now. We're the only program in Middle Tennessee that's using it. There is one other program in Memphis, so just the two of us in the entire state. So we feel very lucky that we're able to bring this to Tennessee because there's a lot of lung cancer here.
A higher number of lung cancer cases than in other parts of the country?
Yep. We have a lot of smokers. We have a lot of people who've been exposed to asbestos, whether it's been in the military or working in auto body or tearing down old homes where we know that the asbestos sits in the plaster and in the tiles.
Oh, wow. What is the gas that seeps up through the
radon?
Radon.
Yeah.
Don't we have a high incidence of radon?
We do. Especially, because there's so much bedrock in Tennessee. You know, anytime you're seeing someone try to build a driveway or a home, they're always running into rocks. So there's that. And a lot of people get over that by getting a radon test, and then you can easily get a mitigator. But we mostly see that in basements. There's not as many basements here in Tennessee as there are in places like Pennsylvania where there is a high amount of radon. So I do think that contributes to it, yeah.
Okay. So we were talking about the drug that kind of lights up the cancers so you can get them. I know this is going to sound stupid, but what is a cancer? What has happened to make something turn into a cancer or start growing?
Yeah, great question. Smart question. Cancer comes from the Greek word for crab. And so the idea being that the edges of it are pinched in, and that's sort of from the very early days of when people didn't have microscopes or things like that. But basically, it's the transformation of normal cells into abnormal cells, and they keep growing. And part of the problem is the body doesn't identify them as being foreign or other because they started from us. And so they're able to continue to grow. And there's all types of cancers in the body. When we talk about lung cancer, though, this is really a disease that we promoted by the creation of cigarettes and the mass production of cigarettes, because before the mass production of cigarettes, before World War I, the incidence of lung cancer was about 1%. And what most thoracic surgeons were really trying to do was to take care of TB. So all of the procedures that we originally invented, whether it's removal of part of the lung or it's draining it for an infection, we were really fighting TB for hundreds of years.
Wow.
And that's the origin, really, of thoracic surgery. It's only since the advent and mass production of cigarettes that we've really seen an upturn in lung cancer.
So, Dr. Lazar, when you walk by somebody and they're smoking, you just want to smack that cigarette out of their hands?
I do. I really do.
I knew it. So if you're just joining us, I'm Anna Marie, and this is Focus, and we're talking with Dr. John Lazar, the Chief of Thoracic Surgery and the Director of Thoracic Oncology at Ascension Saint Thomas. Are the cases of lung cancer, since we tend to have more lung cancers in Tennessee than in some other states, what about men versus women, young versus old? Are there differences there?
Yeah. So in the last 20 years or so, we've seen, you can't smoke in a restaurant, you can't smoke at a bar anymore. And so people have stopped smoking. And once that started to happen, the rates of lung cancer have gone down in both men and women. And it's sort of plateauing now. I would say that, unfortunately, in Tennessee and some of the other southeastern states, it's still pretty high compared to other states like New York, California, Illinois, Massachusetts, some of those states. But I do think it will eventually come down. Where we're nationally seeing a rise is in a group that we never expected, which is younger women, 40 to 64 years old, who have none of the risk factors that we associate with lung cancer, whether it's, exposure to Agent Orange or asbestos or radon or cigarette smoking. They don't have any of those. And right now, the only screening tool that we really have is a CT scan, which is great. But the problem is you can't scan every single person in the United States. So one of the things that we're working at very hard at Ascension Saint Thomas is we are partnering with cardiology, because we do know that there are identifiable risks in women with coronary artery disease and heart attacks. And they have the director over there and I are partnering to bring awareness to lung cancer in this group of women. So what does it mean? Unexplained weight loss, fatigue, coughing up, blood. Like, why would a 45-year-old woman be doing that? So reason to go to the doctor. Another thing is you get a chest x-ray in the emergency room and they're like, oh, we see some small growth, probably nothing. Repeat the x-ray or a CT scan in 1 year.
Yeah.
And they brush it off. Don't brush anything off.
Yeah.
So we're trying to educate women about any clues that may be in their health. The other thing that's going on is there's a lot of the local radiology groups will be advertising calcium score CT scans to look at the coronary arteries.
Yeah.
And the other thing is you can, for a very minimal cost, probably add on a CT scan of your chest just to make sure there's nothing there. And if there's nothing there, you could probably do nothing for 4 or 5 years and then repeat it. You could probably get a chest x-ray every year. I mean, we're really trying to work things out. I think the next innovation would be a blood test, and we're getting very close to that.
So what would a blood test show for you to know that something's happening?
Yeah, so a lot of these tumors are going to be shedding some of their DNA. And the idea being that the serum, which is another name for blood, we can then draw some blood, run it, and we will look for the DNA of the tumor to be in there. And then that will help us focus and think about how much easier it is to go get a blood test than it is to get a scan or, to sort of not know one way or the other whether you have it or not.
Yeah. How is the DNA different in a cancer than in just your regular blood in your system? What are you looking for?
Right. Well, you're looking for sort of like the signature of the tumor. So there's certain types of cancers that are in the lung, pretty much 3 types. There's the traditional lung cancer ones that you think of, which are squamous cell carcinoma, adenocarcinoma. They fall under this thing called non-small cell carcinoma. And then there's another version which come off of basically nerve cells. It's more complicated by that, but let's just keep it there. And then the idea being that as they grow, they shed the same way that you may shed skin, and they leave a genetic fingerprint when they do that.
Goodness.
And so then that way, when we draw the blood, we're looking for that fingerprint. We're looking for that signature.
Okay. One of the things you just said seemed so interesting to me. You said finding that there could be a relationship between coronary artery disease and lung cancers in women who otherwise have no risk factors, no visible risk factors.
Correct.
So is that going to be considered a risk factor? Is that something that gets your attention?
Not necessarily when you think about it in that group, but one of the things that we're studying specifically right now is how we can improve lung cancer screening. And one of the ways in which we're doing it is we have Saint Thomas Heart, which is where thoracic surgery sort of lives within the organization, has the busiest heart program in Tennessee. And if you think about all these people who are getting valve surgery or heart surgery, or, they're fixing their blood vessels, they're constantly getting all these CT scans. And a lot of these patients are the same patients who have a lot of the same comorbidities, meaning the same illnesses, whether it's diabetes, history of smoking, secondhand smoke from their parents. And so what we're really trying to do is work with St. Thomas Heart on the cardiology and the cardiac side, taking their CT scans and looking for other types of problems that may be sitting there, but other people are not looking for. And in a preliminary study that we did, the CAT scans are usually finding cancers 3% of the time in the high-risk people. We're getting to 20 to 30% cancer rates in these groups. So this seems like a logical way to then look at the women who may only have cardiac risk factors. Say you're a 50-year-old female, your mom died of a heart attack at 60, your primary care physician or your cardiologist may say like, hey, we need to be screening for you because we know that women have coronary artery disease are much different than the men who have coronary artery disease. And my point to that team is, hey, if you're going to be scanning the heart just get another foot above it. Let's scan the whole chest at the same time, because the low-risk people may not have the same risk factors as the people that I described in the beginning.
Right.
But we're already getting them in, so why not continue the screening process?
Yeah. I think that's fantastic. You know, those of us who are not in the medical field and who go to our doctors and go to our physicians have for a long time thought, well, why can't they all just work together?
Yeah.
And I love that you guys are doing that collaboratively.
Yeah, and I think, the healthcare system right now is fairly taxed. Getting in to see your primary care physician and you may have 2 or 3 problems and they're like, listen, you came for one. My dad was a primary care physician, so I understand firsthand some of the things that they go through. Mm-hmm. On the other hand, I'm trying to get people in Tennessee to be advocates for themselves.
So when we go to our doctor, what kind of things do we need to ask about? Like me, I'm overweight.
Yep.
I'm in an older adult.
Mm-hmm.
Are there certain things that I need to be asked? I know that for a fact I asked about osteoporosis. I said, should we screen me for that? And he went, yes, of course. And then we did. And so now I'm on calcium supplements.
Right.
But what else should we be asking about to find out to make sure we're kind of covering that and still have healthy lungs?
Yeah. So I think there's some true basics. Obviously, this is not a thoracic surgery type of thing.
I know, yes.
But I think, as we all get a little bit older, we got to be thinking, top down. So, you think about your eyes, like how is the pressure of my eyes? Is my retina there? So you go to your eye doctor. You think about your teeth. The health of your teeth is very important because they can spread a lot of diseases. There's a lot of bacteria there. So seeing the dentist, that's not always the easiest thing to do.
Sure.
And then kind of moving down, you think about your thyroid. As we get older, sometimes the levels go up, sometimes they go down. So you can gain weight, you can lose weight. Thinking about your heart, blood pressure is very important. That's also a contributing factor to that. Do you have a history of heart problems? So saying like to your physician, hey, I know you just did an EKG, but that's just looking at the rhythm of my heart. What about something that's going to look inside, like the coronary arteries? So I think that that's very reasonable. These scans tend to be less than $100, and in some cases, they're covered by your insurance. Mm-hmm. And then just kind of moving down, making sure you have good GI health, that your kidneys are okay. Obviously, you worry about diabetes and prediabetes because that can basically, make all of these problems much worse. There's plenty of people who are overweight, but just making sure that you eat healthy and that the portions are okay. You worry about how much alcohol you take in. A little's okay, a lot's not so good. And staying active.
Are there things that contribute to the growth of cancers, lung cancers, thoracic cancers? Yeah,
there's a lot of good information about that. There's a lot of urban myth about some of that. I would say the most popular thing being discussed about that is sugar. Mm-hmm. A lot of my patients are very concerned about how much sugar they're taking in, not just their glucose levels or the A1C levels, which looks at, over 90 days, how your sugars are doing. And some of that is true, but some of it is, you can take it too far like anything else. Mm-hmm. There's also a lot of discussions about supplements. My only thing about the supplements are if it can do some good, there's also going to be a risk associated with it. So you have to be careful. And if you're going to be taking them, you should probably talk to your primary care about, the pluses and minuses of that. Especially if you're taking a lot of different medications, they can interact with those medications.
I didn't know supplements had minuses.
Yeah.
I didn't know that. And
right
at this point in my life.
Yeah.
So is that something that you would ask your patients? Would that affect a lung cancer?
Not necessarily, but like it can make it easier for you to bleed. So we have sometimes stop those supplements prior to surgery.
Sure.
And then, I think, drugs like Ozempic, we're still learning about a lot of the effects that they're having on the body.
That's the weight loss, one of the weight loss drugs?
One of the weight loss drugs, exactly.
Oh, boy. Does it have possible implications for the lungs as far as you know?
No, I don't think it does. But I think, a lot of our patients are coming to us really well educated. They've done a lot of reading. They've been on the internet. And so they have very in-depth, questions. Unfortunately, we're not able to answer all of them on that. But I mean, I think, the usual things are probably the safest, which is staying active, a well-balanced diet, and avoiding anything, that's bad for you, like whether it's vaping or smoking. And the problem is that, you get to a certain age, you've been smoking a very long time, and it's one of the guilty pleasures that you kind of have left in life. Mm-hmm. And then you're going through a stressful thing. It's very hard to quit smoking at that point. And we have a smoking cessation counselor that we like very much, and she works with our patients very closely, but it's still, I would say they usually stop smoking. I mean, they all stop smoking because I won't take them to the operating room if they're vaping or smoking. Mm-hmm. The issue is whether they start again afterwards.
Oh, I want to make sure that you realize we're talking with somebody who really, really has some information that could change your life. Dr. John Lazar, Chief of Thoracic Surgery, Director of Thoracic Oncology at Ascension Saint Thomas. If someone has smoked for a long time and then they stop, have they already done damage to their lungs that's irreversible, or can the lungs heal?
Well, they definitely can't heal. It's not like the liver where you can do damage and it can repair itself. The advantages of quitting smoking are that you stop doing the damage to the lungs. And basically, we can see a lot of this stuff on CT scans. The nice thing is there's a lot of drugs that can optimize the residual lung function that you have. Mm-hmm. As a surgeon, I don't usually deal with that. Usually that's the medical side of it, which is called a pulmonologist. And they're the ones who kind of they're the people at the forefront, or your primary care doctor can help you maximize that. But the benefits are incredible when you stop quitting smoking. First of all, you're going to see a nice boost in your wallet.
Yeah.
And then after that, the thing is, your blood pressure, the effects on the heart, the blood vessels, and obviously the lungs. There's this thing called lung cancer screening, and you can qualify being anyone 55 to 80 years old. You smoked about a pack a day for 20 years, or you smoked half a pack a day for 40 years, somewhere around there, and that you have no signs or symptoms of cancer, which is, unexplained weight loss, fatigue, coughing up of blood. You would qualify for this. This is covered by the federal government and your insurance for these scans. You can also have quit smoking within the last 15 years. So you can be an active smoker or a former smoker. And right now, that is the best screening tool that we have to help prevent lung cancer. And part of the thing is a lot of things that we find are these things called nodules. And nodules in the lung are basically anything that are smaller than 2 centimeters, which is about 3/4 of an inch. I kind of compare them to freckles. Mm-hmm. We all have freckles, but we all don't have skin cancer. You understand what I'm saying? So a lot of them are just there from, you had inflammation, you had an old infection. But the idea is that we watch those and we try to biopsy them early on. And what do we mean by biopsy? Meaning putting a needle into it and getting tissue from it to get you a diagnosis. Mm-hmm. So a lot of times, especially in this area, it's an inflammation of some of the lung tissue called a granuloma, which is meaning non-cancer. And then there's a bug, well, it's really a fungus called histoplasmosis, which we inhale all the time here in Tennessee. And if for whatever reason our immune system is lower that day, they can kind of fester in the lungs. If you're a former smoker, your ability to fight any kind of infection in the lungs is lower because the smoking has destroyed some of the architecture that you had there. So the blood going out to that part of the lung is not as good. So the ability to get antibodies out there, which is what helps us fight infection, is a lot lower. So there's a lot of different things that grow in the lung. And I would say the vast majority of them have no implication on our long-term survival.
At what point do patients come to you? And then what do you tend to find? Or do you tend to find that it's more something small, something that's not cancer, or by the time someone comes to you for surgery, is it very serious and you have to find some way to do something to make their lungs work better?
Yeah. So I would say that we are in thoracic surgery, we're very big gatekeepers, and there's a whole spectrum of things that we see. So, in the worst case scenario, yeah, I see things that are big. They're going to be a problem for that person, and we have to come up with a very deliberate plan, meaning something that's got a lot of layers to it, and it could mean involving medical oncology, radiation oncology. It may mean more than one surgery. On the other hand, I see plenty of people who are seen in the emergency room. Maybe they had constipation, or they had just felt fatigue, or they were, and they went in and they got a scan or a chest x-ray and they saw something abnormal, and they just get sent to me. And then it's my job to kind of get to the bottom of it. So you have everything, ready for surgery. They know they're going to get surgery to what the heck is it? What's the next step?
Wow. Dr. Lazar is the Chief of Thoracic Surgery, Director of Thoracic Oncology at Ascension Saint Thomas, and we're almost out of time. So we hear a lot about minimally invasive surgery. Is that the same as robotic surgery?
Minimally invasive surgery, you can think about it. You probably know somebody who got their gallbladder taken out, and it was taken out with 3 small incisions that are about 1/4 of an inch. And that's minimally invasive surgery, meaning you made an incision, you put a port in, a scope went in to visualize everything, and then all the other instruments are then brought in through ports. We do the same thing in the chest. It's not called laparoscopic. It's called thoracoscopic, thorax chest. Another name you may have heard is something called VATS, V-A-T-S. And what robotic-assisted surgery is, it takes VATS, but it takes it and makes it so that the instruments are wristed. So you go inside, and instead of operating with 2 chopsticks, you're operating with your wrist and your fingers, and you have greater precision. And then in addition, the laparoscope or VAT scope is 2D. So when you look at your television set, you're just seeing it in 2 dimensions. The robotic scopes have 2 cameras built into them. And so you have one for your left eye and one for your right eye. So everything that you see is in 3D. It's wristed. It's almost as if the surgeon is actually right inside your body and operating about 2 to 3 inches away. So operations that only could be done open because of the complexity now can be done minimally invasively because we have this robotic precision. One of the areas in which we're expanding robotics is in something called interventional pulmonology, which is using your CT scan to create a GPS roadmap.
Oh, my.
And then we put the scope in, and then the robotic bronchoscope goes down, drives out right to it, and then you put a needle into it. And that's how we're able to get into these 4 or 5 millimeter lesions. My partner, Dr. Otis Rickman, who's part of Thoracic, he does these procedures every week with me, and we are constantly sharing cases so that we can help people. In addition, one of the things that we are working on as sort of the next innovation that I'm hoping to bring to St. Thomas is actually curing the cancer or helping to deliver chemotherapy or some sort of agent through the bronchoscope or through the surgical robot so that we can avoid big incisions and things like that, shrink the tumors, bring them back, and so they only need something smaller, and that's called therapeutic. So right now it's just diagnostics, meaning we can diagnose things. Mm-hmm. But the holy grail will be to basically diagnose you and at the same time treat you. So then you walk out of the hospital being like, I got diagnosed, but you know what? Now I'm already started my treatment.
That's amazing. From having to have your whole body treated mm-hmm. to the cancer treated.
Yeah.
That is amazing.
Yeah. Thank
you so much. Dr. John Lazar, Chief of Thoracic Surgery and Director of Thoracic Oncology at Ascension Saint Thomas. Thank you for joining us.
Thank you.
We're going to put some more links on our Focus Facebook page so you can check it out and find out more and learn a little more about being your own good advocate. Thank you for joining us today. Make sure you listen again next week. I'm Anna Marie. That's Focus.